Hi, I'm Jeff Klein, editor of RadioGraphics, and today I'm pleased to have with us Dr. Farhood Saremi from the Department of Radiology at the University of Southern California, who is the first author of one of our featured papers in the current November 2018 issue of RadioGraphics. Dr. Saremi's paper is entitled Image Predictors of Treatment Outcome Following Thoracic Aortic Dissection Repair. Farhood, welcome to our podcast.
Thank you for the invitation, Dr. Klein.
So, Dr. Saremi, radiology papers dealing with aortic dissection tend to focus on the imaging diagnosis of dissection and its variants. Your paper in the current issue addresses the evaluation of patients successfully treated for dissection with the newer minimally invasive methods of endovascular repair that are increasingly used to manage some of these patients postoperatively. It looks like your institution has quite a large experience with these patients. Is this what led to your exhibit and the subsequent paper on this topic?
Yeah, that's true. Our institution is actively involved in performing different aortic vascular surgery, including TEVAR. So we probably perform something, some 12 to 17 TEVAR per week. Wow. And the result will be presented in our bi-weekly aortic conferences. It's a multidisciplinary conference. And we discuss interesting cases, showing images. And we also receive a lot of referrals from smaller institutions around us. And we discuss those cases.
Terrific. So now your paper begins with a review of the classification system that's used for characterizing aortic dissection. And then it addresses the use of CT, MR, and intravascular ultrasound. Can you describe the CT angiography technique that you employ in evaluating these patients?
Right. It's not very sophisticated technique. It's the same technique that can be used in every institution. Probably the most important factor is the amount of contrast and the rate of injection, and also the timing of the data acquisition. These are probably the most important factors. So like any other CTA technique, we usually, especially for these cases, we start with one non-contrast image. Non-contrast would help in acute situation to show the intramural hematoma, as you know. But in these cases, especially after surgery, like type A repair, would be important because it shows the area of suture placement, sometimes, the Teflon material that you see in Teflon felt, and also the stent itself. So if you use just post-contrast, in some cases, some of this material may be confused with tiny pseudoaneurysm or even small leaks. So we usually get one, at least in the serial images that we do for these cases. When it comes to post-contrast study, we decided to perform two sets of data. One is that the peak of aortic enhancement, which is usually 25 seconds, 30 seconds after injection. And the second set, depending on the type of a study, is approximately 15 seconds to 20 seconds after this one. So both are arterial. One is early arterial and the second one is late arterial in order to show the dynamics of the false lumen filling. We thought that these two sets would be enough, and radiation is acceptable somehow. And in terms of triggering of the contrast, what we do, we usually put the trigger point at either ascending or within the left ventricle. Because sometimes when the technology decides to put it in the descending thoracic routine area, it may falsely place, and they don't know in the false lumen, and that actually causes some problems. So the easiest way is just to put it in the ascending or left ventricle in order to start the triggering.
Yeah, that makes the most sense. So now, afterwards, your paper goes into the treatment of dissection, particularly the use of thoracic endovascular aortic repair, or TEVAR, in the management of patients with type A and type B dissections. Let's talk about the management of type A dissections, and we'll show figures 1 and 2, which provide a flow chart, which is figure 1 of treatment based on the Stanford classification, and a diagram of the different forms of treatment.
Right. So TEVAR, it's in general, TEVAR is performed in two groups of cases after dissection. Probably the most common application is cases after repair of type A. And the second group is for complicated or emergent type B situation. In group with type A repair, as you know, most of the surgical procedure, as we know, is the standard of treatment in these cases. And the initial approach for treatment is usually a form of a primary AR repair, which includes a supracoronary AR replacement plus resection of the intima. And also, in some cases, they do aortic valve repair if there is any form of aortic regurgitation. And in rare cases, they may replace the aortic valve. This is called primary AR repair. And after that, they usually stop it and follow these cases. So somehow they convert the type A to type B, basically. So by the time we see these cases, we see some changes in the ascending aorta with a type B form of dissection in the remaining of the aorta. So in these cases, if we pay attention, almost 2/3 of these cases, when we review the images, show a large proximal intimal tear. It's still filling the false lumen in 2/3 of the cases. And 50% of these cases may show growing of the descending aorta and distal aortic arch in the follow-up examination. That's why, because of this complication, some surgeons prefer to do a second surgery or extend the type A repair to a form of hemi-arch or total arch in the form of elephant trunk or frozen elephant trunk. So even in this type of surgery, they may decide to combine the surgery with a form of antegrade TUR at the time of surgery, or stop it and do a retrograde TUR the way that we know in the follow-up examination. So these are the main management of the type. So these are the form of treatment that the radiologists see after the manipulation of these cases.
Terrific. So your next section deals with the technical considerations of TVAR, and it details the role of imaging in the management of dissections. Can we talk about the use of CT angiography for classifying the proximal landing zone for endovascular repair? We'll also take a look at a case where there was incomplete coverage of the proximal landing zone. So we'll show figures 4 and figure 6 here.
Sure. Obviously, the decision for classification of the landing zone is not only for the type B cases, but for repair type A too. So historically, the surgeon decided to classify these in order to find a very nice platform for the placement of the proximal part of the stent. It's called proximal landing zone. So the landing zone should be very stable. In order to create this stability, obviously there are many factors in the aortic arch that may interfere, including the orifices of the arch vessels. So in the best scenario is that the dissection occur in the distal, the classic type B, distal to the left subclavian artery, and the coverage is relatively simple. So in this group, which are basically the type 3 and 4, the surgeon need approximately like 15 to 20 millimeter clean zone in order to place the stent. But in reality, most of the cases that are scheduled for TVAR are the one that need to have some sort of coverage of the left subclavian, the so-called zone 2. So in these cases, they need to cover the left subclavian. So radiologists need to know different form of aortic arch in order to understand what the need of surgeon will be. For example, the tortuosity of the aorta is very important in order to make a nice sealing. It is shown that in very tortuous arches, the landing zone should be longer in order to make a very stable and prevent leakage around the stent. The second is that the variation of the arch is also very important. As we know, cases with a very low insertion of the left vertebral artery to the left subclavian artery need to be reported. Also, those vertebral arising like 1 to 2% arising directly from the arch, and we need to report those. In these cases, the surgeon may decide to do the bypass instead of, for example, a transposition of the vessel. So these are the other thing that radiologists need to review when they assess this arch vessels is to demonstrate the total plaque burden and also the amount of calcification in the arch. So these are important factors in addition to the form of classification that we usually describe in our reports.
Great. Can we take a look at Figure 6, which I think is a nice example of incomplete coverage of the proximal landing zone? Can you take us through those images, perhaps?
Right. In this is a relatively nice example. This is actually a class of dissection which is classified as landing number 3 or 4, for example. So in this case, the surgeon obviously covered the area of a tear in the proximal distal part of the arch, which is shown by a yellow arrow in the image. This is the first image. Image A is before the placement of the stent. On the second one, you see the edge of the stent, the proximal edge is approximately 1 centimeter distal to the same area of tear. So two things happen. Either the surgeon didn't cover that area completely or the stent migrated. So if the aorta is too large or the sizing is not good, the stent in the follow-up examination may migrate a little distally and open the area of tear. Or for some reason, the tear extends to the more proximal part, and we see it again in the follow-up examination. Whatever happened, the surgeon, in these cases, whatever the scenario is, the surgeon decides to go and put another stent and cover the area of leak. Or in this case, they may decide to cover the part of the subclavian in order to make a secure landing area.
Terrific. So now the last part of your paper discusses aortic remodeling. Can you describe the concept of remodeling for our audience and how it is assessed on CT angiography, why it's important to be considered, and what is meant by positive and negative remodeling? And we're going to look at Figure 15, which shows several cases which nicely illustrate the concept of remodeling of the true and false lumen.
Right. Remodeling is a concept that, this term is used for some vessels, including coronaries and also aorta. So when we talk about remodeling, in whatever measurement that we use, either by the diameter or area or volume, we usually use the term remodeling when we see greater than 10% change in those measurements. So this could be positive or negative. So positive remodeling in general sense is a form of favorable remodeling and applies to both false and true lumens and also for the total diameter of the aorta. So in case of true lumen, when we call it positive remodeling, it means that the collapsed aorta after the dissection should go back to the normal state in order to be called positive remodeling or favorable remodeling. The opposite is the case for the false lumen. So the expectation is that after placement of TVAR in the follow-up examination, we need to see some sort of decreased size of the false lumen in the long run in order to call it a positive remodeling for the false lumen. So this is called also a favorable response for the false lumen. So these are the general terms that we use. So then it comes to the typing of this remodeling based on the age of the dissection. So in general, nowadays we classify dissection in three groups, like acute, subacute, and chronic. Acute is usually approximately 1 or 2 weeks, let's say. And for subacute, up to 3 months, maybe a little more. And for chronic, is usually more than 6 months. So in reality, most of the cases that is categorized as repair type fall in the category of chronic dissection because they have been there for at least for a few months. So in these cases, we don't expect to see a rapid response after treatment compared to those cases that come to the emergency department and treated emergently, or in those cases with subacute dissection, we see a better response. Let's start with these cases. So we have 3 cases in this image. Case 1 is showing a case of hyperacute dissection. So we see intramural hematoma. The surgeon decided to place the stent, and we see that in 1 month that the entire false lumen is gone, and the true lumen is completely back to normal state. So it's the reason is quite obvious, because the false lumen is filled with fresh blood or recently dissected, so we expect to see rapid remodeling. An important thing for radiologists to know is that this remodeling is not only limited to the area of stent, but also to the descending the thoracic aorta, and also to the abdominal aorta, to the remaining of the aorta. In case 2 is a form of subacute dissection, and after placement of the TEVAR, we see that within 2 years, the true lumen is almost completely normal, back in shape, and the false lumen is also a little smaller. True lumen usually goes back to normal state within 6 months, but in these cases, false lumen may take up to 2 years to return to resorb or show visible decrease in size. In chronic state, because the lumen is filled with organized clot, or in some cases like this one, partially calcified, we don't expect to see much remodeling, but and it's still debate, regarding treatment of these cases with TEVAR, but some surgeons still perform it for different reasons, and you may see a little remodeling in the long run, as shown in this case number 3.
Terrific. So Farhood, finally, let's discuss negative remodeling as a result of failure of closure of the false lumen. And we'll look at figure 19 here, which I think nicely illustrates that concept.
Sure. Negative remodeling, as I said earlier, for false lumen, meaning that in the follow-up examination, you see enlargement of the false lumen. So in the initial measurement, if the false lumen diameter is greater than 20 millimeter, you may expect to see some enlargement without treatment, obviously. And also, if the size of proximal intimal tear is bigger than 1 centimeter, again, it's not a good sign. We have to report it. So we always measure the size of this tear in the proximal. Another factor that radiology need to evaluate is the presence or the size of the distal reentries, distal fenestrations in the intimal distally. So that's why we need to review the entire aorta. So the scenario that is shown in this example is a case of a dissected aorta, and in both examples showing it's a type A repair of dissection. In addition to that, we see filling of the false lumen with different mechanism. In patient with repair type A, in general, in the follow-up examination, there are 3 main reasons for enlargement of the false lumen. The first one is remaining proximal tear, obviously. The second one is retrograde filling of the false lumen from a dissected flap of one of the arch vessels, which extend into the false lumen, as shown in this case. And the third reason is leak around the distal anastomosis that they place. So we need to look for all this condition. And they may be all together. So it's very important to find all these reasons, because surgeon may decide to work on one of these, but later in the follow-up examination, you see that it's still, you see some sort of leakage. So these are the main reasons that shown in these two examples. In the images, there are 4 images in the lower part of this figure. The first image is performed during early arterial phase, and the second and third are axial and coronal images during late arterial phase. If you look at the axial images in the upper row, comparing the false lumen, we see that in the late image, there is a delay emptying of the false lumen, and contrast just sit there. This is a very important radiology sign, meaning that the false lumen is being filled from some sort of leakage proximally, but the drainage is not complete distally. So you would expect increasing diastolic pressure in this case and increasing size of the aorta in the follow-up examination. So this is probably the most important thing radiology need to pay attention. So in the last image, which is a study performed 7 months later, we see enlargement of the false lumen as a result of this problem. So in this case, the surgeon decided to do change the type initial repair to the hemi-arch repair in order to get rid of those leaks proximally.
That's a very important concept, because I think the concept you raised initially, which is obtaining sort of 2 phases of scan, in particular,
right,
late phase, you wouldn't really appreciate this phenomena unless you had the information available from the later scan showing the delayed filling and emptying of the false lumen and the reasons as to why obviously this became a problem later down the road. So terrific. So Dr. Saremi, I want to thank you for taking the time today to discuss your paper, which is on image predictors of treatment outcome following thoracic aortic dissection repair, again, which can be found in the current November 2018 issue of RadioGraphics. Farhood, thanks so much for your wonderful paper and for taking the time to discuss your paper with us today.
Thanks a lot. Anytime, Dr. Klein.